Welcome to the AUA News Inside Tract podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Welcome to the podcast. My name is Karen Johnson, and I am AUA's Director of Quality and Measurement. Today, we'll be discussing diagnostic excellence in urology. Diagnostic excellence is a fairly new concept that has emerged as a model to support the delivery of high-quality, effective, patient-centered care. Of course, diagnosis is foundational to all medical care, but it can be challenging, perhaps particularly in urology. We'll discuss that and more in this podcast. Our guests today are Dr. Matthew Nielsen and Dr. David Friedlander. Dr. Nielsen serves as chair of AUA's Science and Quality Council, or S&Q Council, and Dr. Friedlander is a past S&Q fellow and now serves on AUA's Quality Improvement and Patient Safety, or KIPS, committee. I'll ask each of them to tell us a little more about themselves, and then we'll get into our discussion. Dr. Nielsen.
Thanks so much, Karen. It's really great to be with you today. My name is Matt Nielsen. I'm, in addition to the AUA Science and Quality Council chair, professor and chair of urology at the University of North Carolina at Chapel Hill. My clinical practice is focused on urologic oncology, and I'm really excited to have this opportunity to share this topic with our listeners today.
Thank you. Dr. Friedlander.
Yeah, thanks again, Karen, for this great opportunity. I, too, serve on the faculty at UNC with Dr. Nielsen, where my clinical practice focuses on endourology, namely the management of stones and benign prostatic hyperplasia, whereas my academic interests focus on trying to elucidate facilitators and barriers to high-value care, which we traditionally think of as outcomes achieved per dollar expended.
Great. So thank you for that. So let's get into our discussion. I started off by saying that the concept of diagnostic excellence is fairly new. So before we get into that, let's back up a step and talk first about diagnostic error. Dr. Nielsen, can you describe that concept and then go ahead and define diagnostic excellence and talk about how they're related but different concepts?
Excellent. Yeah, it's my pleasure. So the National Academy of Medicine defines diagnostic error as, quote, the failure to A, establish an accurate and timely explanation of the patient's health problems, or B, communicate that explanation to the patient, unquote. An inaccurate diagnosis is imprecise, incomplete, and/or differs from the true condition that a patient has or does not have, and includes wrong, miss, and partial diagnoses. A non-timely diagnosis is one in which there is a meaningful delay, perhaps minutes in some situations, but much longer in others. And unfortunately, sometimes errors in diagnosis lead to patient harm. However, diagnosis is both an endpoint, i.e. a label, and a process. This process happens over time and includes information gathering, for example, via clinical history and interview, physical exam, diagnostic testing, and referral and consultation, integrating and interpreting that information, and eventually coming to a working diagnosis. Often the process is iterative. As part of this process, the clinician will communicate the working diagnosis to the patient, and together, decisions about treatment are made, which in turn may help to refine or verify the working hypothesis. The National Academy of Medicine published a report on diagnostic error and really gave us a call to action to improve the whole diagnostic process across the House of Medicine. And the Journal of the American Medical Association published a series of really informative articles on this topic, covering all the different elements and dimensions. Yang and colleagues in their 2021 JAMA paper defined diagnostic excellence as, quote, an optimal process to attain an accurate and precise explanation about a patient's condition. An optimal process would be timely, cost-effective, convenient, and understandable to the patient. An accurate and precise diagnosis gains clinical value insofar as it leads to better choices in treatment. In short, the concept of diagnostic excellence provides a framework for thinking about how we can not only reduce errors in diagnosis, but also how we can improve care delivery through the entire diagnostic process.
Thank you, Dr. Nielsen. So, Dr. Friedlander, why should urologists be concerned with diagnostic excellence? Why is this such an important topic?
Yeah, that's a great question, Karen. And as Dr. Nielsen alluded to, inherent in the concept of diagnostic excellence is the idea of diagnostic error and developing strategies to either eliminate it or mitigate it. And, unfortunately, diagnostic error is a big problem in the United States. It's anticipated as many as 5% of adults in the outpatient setting experience diagnostic error annually. Similarly, diagnostic error has been implicated in 6 to 17% of hospital adverse events and up to 10% of patient deaths. So significant consequences associated with it. Similarly, if we think about diagnostic error as a form of healthcare waste, then the magnitude of the problem becomes even larger. It's anticipated that wasteful practices account for up to 900 billion in annual expenditures within the U.S. healthcare system. And if we think about that as a percentage of total expenditure, that could be anywhere from 1 to 5% of all U.S. healthcare spending annually. So tons of opportunity to not just improve patient outcomes and experience, but also reduce costs. I think another important thing to think about is that ultimately, whether or not the outcomes of the diagnostic process are positive or negative, ultimately, we want to use each clinical encounter and diagnostic process as a learning opportunity to determine how we as practitioners can improve the diagnostic process and ultimately patient outcomes.
So when we talk about high quality care, those of us who are in the quality space often refer to an acronym STEEP. So it's safe, timely, effective, efficient, equitable, and patient-centered. These are the 6 dimensions of quality that were articulated by the Institute of Medicine more than 2 decades ago. Dr. Friedlander, can you discuss, and maybe with an example, how these ideas or dimensions of high quality care are exemplified in diagnostic excellence, and maybe even how they are relevant specifically for urology?
Yeah, absolutely. Well, I'm going to certainly harken back to my bread and butter, which is stone disease as an endourologist. And I think, specifically the initial management of someone presenting to the emergency department with acute renal colic really embodies a lot of the STEEP concepts, and specifically as they pertain to diagnostic excellence. So let's go line by line here. So in terms of care that is safe, ultimately we want to reduce errors. And in the case of stone disease, someone coming in that is presenting sometimes with vague abdominal or flank pain symptoms, we really don't want to miss an obstructing stone because of the downstream effects. For example, unrecognized obstructing stone that ultimately leads to hydronephrosis and renal demise. So really important that we're providing safe care. Additionally, we want to make sure that it's timely. Ultimately, if we are able to eventually diagnose that obstructing stone, but it's 6 months down the line, I would argue that the opportunity or window for intervention has passed. And so we need to make sure that our diagnosis is safe and accurate as well as timely. With regards to the next 2 components of the STEEP framework, effective as well as efficient care, ultimately, I would argue that the decision regarding the type of imaging, for example, that we would use to diagnose the stone is of utmost importance. There's a significant amount of data out there debating the utility of renal ultrasound versus CT, for example. For example, renal ultrasound may not be as sensitive. However, if we were to use CTs for every instance of suspected renal colic, we'd likely be over imaging individuals. So I think that really embodies some of these challenges that we face with regards to efficiency and effectiveness. In terms of the last 2 concepts, equitable care and patient-centric care, there is pretty compelling data out there showing that there are disparities both with regards to racial, ethnic, and socioeconomic status as it pertains to both absolute rates of follow-up and the timing of follow-up after that initial encounter in the emergency department for a stone episode. And so ultimately, regardless of the type of diagnostic approach that we ultimately settle on in this particular clinical vignette, we want to make sure that it's being distributed equitably across both clinical and non-clinical factors. And then last but not least, there's a variety of management options available to stone patients. And ultimately, we want to make sure that whatever it is that we're offering to a patient to help manage their symptoms and diagnosis, that it's ultimately consistent with their desires.
Wonderful. So are there any other facets of diagnostic excellence that you want to bring out while we're talking about it specifically for urology?
Yeah, I think there are a couple of concepts that really ring true for the practicing urologist, and that is the concept of uncertainty, both with regards to the patient, but also the practitioner. I think a lot of anxiety and a lot of burnout that individuals experience today are related to uncertainty surrounding the diagnostic process. We as urologists manage several conditions where even in the setting of an accurate diagnosis, the long-term outcomes are unknown. And so developing strategies to provide the most accurate information in a timely manner to a patient could be incredibly helpful. For example, a couple of diseases that come to mind are benign prostatic hyperplasia, stone disease, prostate cancer, and or renal masses. And then last but certainly not least, the concept of caring for certain populations, namely older individuals. We as urologists do have a generally older patient population, and so making sure that any diagnostic intuition or shortcuts that we're pursuing rather, don't lead to unrecognized bias or shortchanging, if you will. So, for example, in the case of older individuals, we want to make sure that we're not or we're cautioning ourselves against the concept of ageism. That is, that we're not shortchanging individuals' desires.
Thank you. So, Dr. Nielsen, I mentioned that sometimes diagnosis is hard. Why is that? And how does this affect the quality of care that urologists would provide?
Yeah, I think it's a really excellent point. With urology, we are in a relatively unique position given the absence of a corresponding medical specialty among our surgical colleagues, such that we end up facing a wide breadth of common diagnostic processes directly interfacing with primary care physicians and specialist practice, and in the example that Dr. Friedlander shared, with emergency physicians. In other words, whether it's related to cancer diagnoses, stones, a lot of the conditions that our pediatric urology colleagues treat, there's not really another provider in the mix other than the urologist and the referring physician. And that is a relatively unique situation compared to many other surgical specialties. Many of the folks that we interact with often don't have the specialized clinical guidance and the focus that we do within urology. And sometimes, given the ubiquitous nature of a lot of these complaints, that can result in missed or delayed care, which can translate into undesired outcomes for patients. It can also sometimes lead to inappropriate referrals for urologists who are already overwhelmed with patients and have challenges meeting the access demands. And ideally, those patients might be better managed or triaged with better collaboration and communication between urology and some of our other colleagues.
So that's actually, thank you, Dr. Nielsen. That's a perfect segue to my last question for you. Recently, our AUA board approved our quality agenda for urology. And this agenda was developed to guide our quality activities over the next several years. So diagnostic excellence is included in this agenda. So would you talk just a little bit about that agenda and maybe give some thoughts about how we're going to address the concept of diagnostic excellence moving forward?
Yeah, thank you, Karen. And thanks especially to you for the incredible amount of work you did helping us put that document together. So as you mentioned, diagnostic excellence is one of 6 priority areas that the AUA believes represent the most pressing concerns for urology and urology practice. To address this priority area, we plan to focus particular attention on urologic conditions where there is substantive overlap in provider specialties, alluding to some of the points we just talked about. For example, access to and accuracy in diagnosis of bladder cancer and prostate cancer in a practice like mine, and advances in the diagnosis of kidney stones in a practice like Dr. Friedlander's. A key strategy and component of this is that we will actively engage with other medical specialty societies, healthcare organizations, and quality improvement experts to foster the needed collaboration and leverage existing relationships and efforts that we have. So, for example, we have grant funding from the Gordon and Betty Moore Foundation and the John A. Hartford Foundation to get the word out about the concept of diagnostic excellence, hence this podcast and other materials that we're developing. We're also developing primary care physician-friendly algorithms, laying out the newest AUA guidelines on the early detection of prostate cancer, which we plan to co-create with primary care colleagues to include both the algorithm and an accompanying infographic describing disparities in prostate cancer care with the benefits of PSA screening for high-risk men, in particular, Black men and men with a family history. We can easily translate this concept to many other urological conditions commonly encountered by primary care physicians or other specialists, for example, hematuria, urinary incontinence, stones, to name a few. Future work in this space may involve the development of performance measures. The National Quality Forum has a committee working on performance measures related to diagnostic excellence, touching on many of the points that we've discussed today, including the interface with health equity and care fragmentation. And I'm really grateful to be a part of that work as well.
Wonderful. So we've covered a lot of ground today. But before we close, is there anything else that you or Dr. Friedlander would like the audience to know about diagnostic excellence or the work that we're doing going forward?
Yes, well, thank you, Karen. As I mentioned earlier in our conversation, I am a bit of a value-based care junkie, if you will, for lack of a better word. And so I think any opportunity to tie concepts such as this back to the concept of value is important. And ultimately, diagnostic excellence is about the patient experience and outcomes, but we also need to be practical in recognizing that we as healthcare providers, healthcare systems are under constant pressure to think about the cost of the care that we provide. And so using diagnostic excellence as a framework by which to think about novel ways to improve the value of the care that we provide, I think is a tremendous opportunity. And I look forward to seeing what the AUA has up its sleeve in terms of developing such strategies.
Wonderful. Thank you. This has been a really interesting and informative session. So thank you, Dr. Nielsen and Dr. Friedlander, for taking the time out of your very busy day to explain this concept and its importance to our field. We also want to give a special thanks to our funders. This podcast has been funded by the Gordon and Betty Moore Foundation and the John A. Hartford Foundation through a grant program administered by the Council of Medical Specialty Societies.
This has been an AUA News Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.